All right. Good afternoon, everyone, and welcome to today's webinar on multisystemic therapy. I'm Sheila Weber, Director of Strategic Initiatives at Lutheran Services in America. And as the Director of Strategic Initiatives, I lead our Children, Youth, and Family Community of Practice and our Results Innovation Lab. LSA is hosting this summer series of webinars on evidence-based practices for two key reasons. First, we believe in improving equitable outcomes for all children, youth, and families in the United States. And one very important way of doing that is by providing our network of children, youth, and family members with additional tools to do so, such as expanding the use of evidence-based practices such as multisystemic therapy. Second, we want to prepare our network to be strong and actively engaged partners in your state's implementation of the Family First Act. The use of evidence-based practices as prevention services to help keep families intact and avoid children entering the foster care system is an important aspect of the Family First Act. And being aware of and able to actively decide if you're interested in providing various EBPs is important so that you can engage with your state child welfare directors in conversation around how services can evolve in your state and communities and the role that your organization wants to play in that process. So this series of webinars is intended to help you in that regard as well. Before we begin, just a couple of housekeeping items. We are recording today's webinar, so all of the participants are currently muted. However, you are able to unmute yourselves, and so we will be pausing periodically throughout the presentation today for Q&A segments, and so go ahead and unmute yourselves at those times and ask your questions. Also, if you need any assistance during the webinar, you can use that chat feature of the webinar and send me a message if you have a question you need my assistance with, or if you have a message or question for the whole group, you can send it out to everyone as well. So feel free to use that chat feature also. Following the webinar, I will be sending you an email with the link to the recording so that you're able to share this with your colleagues or your state partners and others that you feel would benefit from the recording. It will be in the same folder that we're saving all of the recorded webinars, so you can access them all handily in one spot when you go back and want to look at your different resources. So with that, I want to welcome Josh Glade and Lori Moore with MST Services. MST is a scientifically proven intervention for at-risk youth, and more than 200,000 families have been positively impacted by MST in over 34 states and 15 countries. So we're very thankful to have Josh and Lori joining us today to share valuable information about MST with our network. So Josh and Lori, I'll turn it over to you.
Yeah, thanks, Sheila. I'm excited to be speaking to you guys today about MST and keeping families together, which is such an important topic. My name is Josh Glade, and as a managing director with MST, I'm responsible for organizational leadership and providing an infrastructural support system to our talented clinicians like Lori Moore, who's presenting with me. And so Lori's a vice president and manager of network partnerships. And since she's a clinical leader in the MST ecosystem, I won't blab on for too long before handing it over to her. But I will say that I'm incredibly proud to have the opportunity to work with folks like Lori and those watching this webinar, because it gives me the opportunity to participate in a small way in the process of creating life-changing outcomes for families in the greatest need. A key reason that I'm proud to be involved in the MST ecosystem is that our program has been proven through clinical trials to be effective for the youth referred and their broader family. One of the defining features of MST is that it's delivered in the natural environment of the youth, the home, the school, and community. And so a team of therapists is on call 24/7 throughout an intensive 3 to 5 month period. And really what we're doing is providing caregivers with the tools they need to transform the lives of youth and their families. And one of the primary outcomes that we track at treatment close includes keeping families together, where 91% of youth who complete treatment live at home. And so by focusing on the core drivers of negative behaviors, MST is able to create long-lasting outcomes well beyond the intensive therapy period. So MST Services is exclusively licensed by the Medical University of South Carolina to disseminate multisystemic therapy, which is what MST stands for. And MST is a family of interventions for a variety of at-risk populations, including abused and neglected youth and youth exhibiting negative and antisocial behaviors such as substance abuse. So the involvement of MST Services allows MST to be distributed on a global scale with consistent outcomes. So from program startup to quality assurance services, we're able to grow by delivering the same MST across the globe, from Australia to Chile to different parts of the U.S. And MST is currently implemented in 15 countries and 34 states in the U.S. And there are over 2,500 clinicians involved within our ecosystem. MST features the largest body of evidence by far of successful interventions for at-risk youth, and with over $75 million in research funding invested by academic and related institutions, that's yielded 74 studies and nearly 60,000 families included across those studies. So MST is the only intervention for high-risk youth where results have been repeatedly replicated by independent research teams, which is something we're very proud of. And studies are continuing to be published on the outcomes of MST, including multi-decade follow-up studies that show the positive impact to youth throughout, over the course of their lives. So Laura will speak more about MST, but first I want to turn it over to her, and she's going to chat a little bit about the complexity in the child welfare system.
Thanks, Josh, and thanks everybody for joining us today. We really appreciate you taking the time. As Josh said, I'm Lori Moore, and I work for MST Services. My task really today is going to be to talk to you a little bit about the MST model. But before we do that, we want to set the stage for what has us here today, which is the complex struggles of the foster care system. We know, unfortunately, that the statistics of the number of children entering into the foster care system has actually steadily been climbing over the last decade. But with that influx of young people, we also know that the welfare and the foster care systems are actually struggling to keep up. We know that foster care is an important part of the child welfare system. We know it's an important part to address children who are experiencing child abuse and neglect. But we also know that as the system is experiencing stress, that those families and young people who enter into the foster care system, they equally experience stress. So what we're seeing here is some data that we have about the experiences of young people who leave the foster care system compared to those in the general population. And what you'll notice about these statistics is that it's not always favorable to those young people. So for example, we're seeing that their increased likelihood to commit crimes, males 4 times likely, females 10 times likely. We are seeing that they're likely to experience homelessness, unemployment, that they're likely to develop PTSD, develop drug or alcohol dependency, and other mental health concerns. Equally, we're seeing that they're having some educational setbacks. The data is telling us that only about 50% of youth raised in foster care finish high school, and less than 3% graduate from a 4-year college. So again, just thinking about the stress of the system and really the stress of the families, children, and youth who enter into the system. Thankfully, though, there is some help coming for us. The federal government has typically responded to the welfare challenges by increasing funding for the foster care system. However, in February of 2018, policymakers decided to take a different approach. Instead of putting more resources into the foster care system, new legislation is helping us really think about prevention and how can we help young people and families from entering into the foster care system in the first place. I'm sure you've all heard of it, the Family First Prevention Service Act, the FFPSA. And the FFPSA, which is commonly referred to as kind of the Family First Act, really is going to allow states to use federal funds to establish programs that provide preventive care, mental health treatment, in-home parent skill-based treatment, substance abuse therapy. States are being asked to invest in high-quality, research-supported solutions that provide effective prevention services, such as MST. So we're really thinking about how do we keep these young people safely at home. And the key here is we really do want to think about keeping them at home safely and addressing their needs. And so to help states do that then, they've developed some classifications to really think about how will the federal dollars be used. And so just looking at this pyramid briefly, we know that there are promising programs. We know that there are going to be supported programs. And the supported programs are going to be programs that have demonstrated success for at least 6 months after treatment ended. And then at the top of the pyramid are going to be those well-supported programs. And those programs are those interventions that showed success beyond a year after treatment ended. MST is considered a well-supported program. We're in the highest ranked classification, and right now we're one of only 5 programs that are well-supported. So just a little bit more about that then. There were only 10 models that made the short list to be evaluated by the Title IV-E Prevention Service Clearinghouse. And that clearinghouse was developed or kind of had the task to really evaluate things from a very transparent place, really looking at the evidence that supported the interventions. And so right now, multisystemic therapy, as I said, is well supported, and we're approved for both mental health and substance abuse treatment. And currently, we're one of only one treatment models that are supported for 2, and we're the only well-supported in the substance abuse field. So folks are asking, how did we achieve that? And as Josh said, we have one of the richest bodies of evidence supporting MST as an evidence-based treatment. And again, he identified some of those outcomes we're looking for: young people at home, in school, and out of the law, out of trouble with the law. But also we're able to look at substance abuse outcomes. And a recent review demonstrated that MST was able to get an 83% reduction in the use of substances after treatment, an 81% of no new arrests during treatment, and then a 64% reduction in drug-related arrest of MST youth. So really, MST is a treatment that's able to address the mental health and substance abuse of the adolescent and the caregiver. So how do we do that? So I'm going to talk a little bit about the model, and then I'm going to pause and get some questions from you. So as Josh said, we are an evidence-based treatment model, and the model is really an individualized intervention. And I'm going to talk a little bit about how we work to individualize our interventions. MST is a short-term but intensive treatment. We last 3 to 5 months, on average about 4 months. Treatment occurs then in the youth natural ecology, in the home, school, and in the community. And if you look over, you'll see on our slide the ecological model, which was developed by Bronfenbrenner. We often call Bronfenbrenner the grandfather of MST, is best understood of the peers, school, neighborhood, community, and the culture. Thinking community, the neighborhood supervisor that supports the team of 2 to 4, about the sweet spot of 5. And on average, the therapist will really try to work hard and intensively with those families. By doing so, we also provide an on-call 24/7 support. We provide this on-call to our families because we know that crises typically don't occur during business hours, and we want our families to have access to their treatment providers when they need them. So the team will develop an on-call support system. MST typically gets our referrals from the court system, from schools, mental and behavioral health centers, juvenile detention centers, probation officers, and child welfare departments. So this slide will help you understand kind of the interventions that we use within the model. So we say that MST provides a suite of services, And if you look at the outside of the circle here, you'll see a wide variety of different types of interventions. MST relies on evidence-based interventions within our model to really address the wide variety of concerns that complex families are experiencing. This is really helpful to the family because it allows them to engage with one treatment provider, and by doing that, they're able to have their needs addressed, as I said, in their home and in their community. Equally, this is helpful to communities because it allows them to provide services in the most cost-effective way. So we're building in this suite of services within our treatment model. So MST is based on 9 treatment principles. And for those of you who are clinicians like myself, these treatment principles will look and sound really familiar, very helpful in the mental health field. We look at these treatment principles, we use them as kind of our guide for intervention development and implementation. So any intervention that we do within MST should really be guided by these principles. In MST, adherence to the principles is measured by the therapist following the principles. So our families are contacted on a monthly basis, and they really kind of complete a survey that assesses for us how well the therapist is adhering to the model by following these principles. So I'm going to talk a little bit more to this slide than I have the previous ones because I really want to give you a good understanding of what MST looks like. And honestly, people ask us, what's unique about MST? What makes it different? And when I get that question asked, literally I point to my brain and I go, this is your brain. And then I point to the slide on the screen and I say, this is your brain on MST. So first of all, that tells you what generation I grew up in, that you'll know what that slogan's from. But more importantly, what this slide is going to help us understand is how an MST therapist thinks and how an MST therapist acts. And so this analytical process is really our roadmap to intervention development in MST. And this is the way we tailor interventions to be very specific to families. So I don't have a lot of time to go in depth for you for each and every component of the analytical process, but I do want to take a couple minutes to introduce you to some of the steps so you get a good feel for how it's activated. So if you look at the top, you'll see a blue box called referral behaviors. And these are typically the behaviors that a young person comes into MST with that's really causing them to go to out-of-home placement, right? It's those disruptive behaviors. And the MST therapist will work with the family and the referral source to define the referral behaviors. Typically, they're things like truancy, runaway, family conflict, substance misuse. And we really define it by frequency, intensity, duration, and system impacts. And that really helps us then have a really good picture of what does the behavior look like at baseline. From there then, the MST therapist will meet with the family and key participants. And key participants for us in MST is anybody that has a vested interest in the child. It could be the school, it could be grandma, it could be the neighbor who lives next door. We're really trying to find out everybody in that natural ecology that wants to see that child be successful. And we're asking them, what do they want to see accomplished in MST? At the end of 3 to 5 months, how will they know that we've done our job and have been helpful to this family? From there, then, you'll see the overarching goals. Overarching goals for us are those big picture goals. So we use that SMART format, and they are developed based on those referral behaviors, and they're measurable. And they give us what we call our discharge criteria. So we really start thinking about sustainability planning, linking it back to the principles that I introduced on day one. How will we know this family is being successful? How will we be able to discharge them from MST? Looking forward, knowing that they're going to have the skills and resources that they need to really address problems. So each week we're able to measure the overarching goals so that we can see incremental progress or growth in the family and the young person. You'll notice as you look at this roadmap, we often call this our do loop, and it really comes from that computer kind of terminology, do until. And so we're really doing this until we help the family be successful. So as you look at that top of the do loop, you'll kind of see, and sorry, I'm a person that likes to use my hands, so I apologize for that. You'll see the top of the do loop where we have some sequential steps, that referral behavior, desired outcome, and OAGs. But then you'll see the bottom of the do loop, and we often call this kind of the clock of the do loop. And it's kind of a reoccurring sequence, kind of recursive. And here the therapist is running this analytical process every single week with the family so that they're anchored to the do loop. So treatment is going to be guided by this process, and the therapist can really stay firmly anchored. You'll also see on this do loop words of environment of alignment and engagement with key participants and family members. For us, we have a never-ending focus on engagement with family members and key participants. We really talk about MST is something we do with families. It's not something we do on families. And so we're wanting to make sure that we're working in this environment. We're all in agreement. We're all collaborating. We're kind of all moving together. Another thing I want to kind of point out on this do loop is if you look kind of on the left-hand side, you'll see a box that says advancements or assessment of advancements and barriers to intervention effectiveness. So here, the MST therapist is really slowing down to check with the caregiver and the family, how well did the interventions that we had designed with the family, how well did they go? Were they successful? Did they impact the behavior? If they impacted the behavior, we're going to stop and celebrate with that family. We're going to go back to that principle number 2, and we're going to look at that positive and strength focus and identify what skills does the family now have moving forward that they're going to be able to address those challenges. Equally, we're going to look at what we call barriers to intervention effectiveness. And here we're going to take a problem-solving approach. We're going to slow down and say, okay, what got in your way? Why weren't we able to affect change with those interventions? And by asking those 2 questions, we're really helping the family think about what it is that they're learning in MST, what they're applying, and we're helping them problem solve. So again, we're really working to empower the caregiver and the family to be that agent of change. So this is a little bit about our analytical process. What's really important here is to think about how we stay firmly anchored to this throughout the course of MST treatment. So I want to talk about one more step of that analytical process. And I really think this is a very unique part of our model. It really comes from our number 1 principle called finding the fit. You will not hang around with an MST person for very long till one of us will say, what's the fit of that, right? And we're really trying to figure out how does that problem make sense for that family, for that young person in their natural ecology. And so if you look at this, you'll see that in the middle of the fit circle, we put the problem or the area. We help the family define what they want it to be, what they want, to identify the concern as. And then on the outside, you'll see what we call drivers or fit factors. And those fit factors, again, come from the family, and equally they come from the research. So MST is able to use research for highly predictable risk factors that drive antisocial behavior to say, do we have evidence that this holds up in this family, in this young person, in their school, in their community? This goes back to that suite of services that I talked about earlier. This is really how we're able to tailor the interventions for the family, because we're asking the family, what are the drivers that make sense for you and your young person and your ecology? So we're looking at kind of peer drivers and school drivers, family drivers, young person's drivers. So it helps us to make sense with the family of the problem. So drilling down maybe a little bit further then, we have a really nice example here for you of AJ's substance abuse. And so AJ would be someone that would commonly be referred to MST, and thinking about the act that's coming up, common problems that kids end up in the child welfare system is for substance misuse. So we would start with identifying that as that referral behavior, and we complete the fit. And then if you look around the fit, you'll see those drivers that might be causing AJ's behaviors. what the MST therapist and family would do then is prioritize those drivers. So they would pick 2 or 3 and say, here's the top reasons or the top causes why we think AJ's using drugs. Those are the drivers we're going to intervene on. And if we're intervening successfully, swinging around that do loop, we're going to see AJ reduce his substance misuse. So a concrete example could be, we might select boredom, doesn't have other things to do. We might select parents are not monitoring AJ when he's out with his community, and then peer association. And so then the therapist and the family would develop a plan for the family to increase their monitoring of AJ's peer associations, to decrease his access to negative peers that he's using with. And then because he's bored, we look at developing pro-social activities. So the uniqueness of this model is really to help the family think together with us analytically about the problem and really consider all the ways we might intervene on it. So along with that fit circle and really identifying those different ways that we can address the substance misuse, MST teams are also trained in contingency management. Contingency management is a state-of-the-art treatment for adolescent substance misuse. We've integrated it into MST because we've seen that we can get accelerated decrease in substance misuse for our adolescents. So CM is a treatment that is a behavioral and a cognitive behavioral therapy approach, which really lines up very well with the MST model. It has 4 components. And as I said, all teams in MST are trained in CM. And therapists can do what we call a la carte, which means they can pick and choose from the interventions that they want to use with the family based on the family's strengths, the family's needs, the young person's strengths, and the young person's needs. Or they can do what we call full cloth, which means they would implement all 4 components of the CM model. Typically, CM full cloth is used when we see those really high-risk substance abusing behaviors. And again, the decision is made with the therapist, the supervisor, the family, sometimes with a referral source. So just really quickly, some about the components of CM. The first component is a tailored ABC assessment of use and non-use. And this really links back again to our principles. And we're really thinking about those principle number 5, that sequence of events. So we're looking at the triggers, right? The antecedents. What are the people, places, and things that cause the young person to use or are related to their use? And then we're looking at the behavior. And in CM, we're not just looking at the behavior of the substance itself, but what does the adolescent do to get the drugs, right? That's also a part of the behavior. And then the C for consequences, what's the outcome, right? So a lot of our young people experience positive consequences or positive outcomes. So for example, they'll tell us, I feel really great, I feel relaxed, I'm able to, hang out with my friends and socialize. And so they experience that substance misuse in a positive way. But then equally, they could experience it in a negative way where there are consequences like they're not going to school or they're getting in trouble with the law. So we're really looking at those sequences with the young person and the caregiver to then do the next step, which is developing a family drug management plan. And that's really where we take that sequence and help the family think about how can they interrupt that. Again, we're leveraging the strength by saying, how can we use the times the young person doesn't use to help us figure out how to keep them away from substance using events. Unfortunately, though, we can't avoid substance misusing events completely. Our young people get invited to parties. They're places where people just start using. And so we also teach them drug refusal skills. So going back to the slide we have about our suite of services, building social skills is often something we do in MST. And this is a specific social skills training that we do within CM. The point and level system is really what I tell my therapists, it's like a behavior management plan on steroids. We're really helping the family think about what's in their ecology that they can use to positively reinforce or incentivize the young person for not using, as well as to consequence the young person or provide a punishment for when they are using. And again, because we want to empower the caregivers to create change, the drug testing protocol, we teach it to the parents. So they're the ones drug testing their young person. And we do this all within that strong environment of engagement and alignment. And we're thinking about sustainability. We know that relapse is a natural part of substance abuse treatment. So we're helping the family plan and predict for that. A little bit more then about CM and how it lines up really well with our model. I talked a little bit already about the first two bullets in the first box of increased monitoring and increased parenting, providing incentives. But also we have this bullet point about decreased family conflict. So going back to AJ's fit, we had a driver that said AJ has conflict with mom and her significant other. If that was a powerful driver in AJ's sequence of event of use, we would really help the family intervene and reduce that family conflict. In MST, we're doing a lot of work in the family. We're really helping the family in many areas work on that conflict because it contributes to a lot of our referral behaviors. In the middle box, you see that decreased contact with negative peers. What we know from the research is the highest predictor of substance abuse is negative peer association. So again, MST is going to really help to work to replace those negative peers with positive peer association and positive peer activities. You also see there the bullet of improved school attendance. So think back to where we started when we were talking about young people in the foster care system and their outlook for education. We really think in MST that keeping the young person in school and getting good academic grades or improving their academic grades is an important piece of the work we do. And then that last box is around those measurable outcomes. So going back to our do loop, we're really identifying how will we measure success? How will we know that the young person has reduced or eliminated their substance misuse? And then how will we sustain those gains made? So I've talked a lot about how we address one specific referral behavior in MST, which is substance misuse. And we'd really do that for all referral behaviors. But I do want to take a minute and talk to you about how we address caregiver substance misuse. And so in MST, on that analytical process that I introduced, there's typically two ways that a caregiver substance misuse might come onto kind of what we call our radar. The first is when you look at that initial fit of the young person's use. And so going back to AJ's fit, there was a driver of the caregiver's use. If we see and get evidence that the caregiver's use is that powerful driver on that fit, the MST therapist is going to engage the caregiver to work with us to address their use. Equally though, if you look at that do loop and where I talked about kind of swinging around that 9 o'clock place, if we're running a set of interventions and we're finding that the interventions are not successful and we're looking at that barriers, right, and we're saying what's getting in the way, we sometimes see that the caregiver's substance misuse is getting in the way of them being able to do those interventions. So for example, a caregiver might not be able to monitor their children because they're under the influence. And so we see that as a powerful driver in the treatment process that needs to be addressed within MST. And really, we do it almost in the exact same way that we do in adolescent substance abuse treatment. We look at those sequence of events, we complete that fit assessment with the caregiver, and we really prioritize those drivers. Here, we're really thinking about health risk related to use. So we're talking to the caregiver about things like HIV, AIDS, hepatitis B, C, tuberculosis, right? Are there any health risks associated to their prolonged use? We're also then thinking about those other types of ecological drivers. Again, the effect of the drug itself, the social ecology. Most adults use substances within the context of their peers. And also with the adults, we're thinking about the impact of trauma and mental health difficulties. So we are a trauma-informed care treatment, and we're really trying to think about how does that trauma interface with the caregiver's substance misuse, or how does their mental health concerns, are they co-occurring? And so we're going to look at those proven and promising strategies that work. And because we know from the research that treating an adult in a more restrictive environment really does not demonstrate more effectiveness either in the long term or in the short term. MST is going to treat this via our home-based model. And we're going to use these type of interventions that we have up here for you on our slide. We're going to do those cognitive behavioral strategies, right? Again, we're going to be thinking about that sequence of events. And often with adults, we're looking at a permission-giving cognition, right? They say something to themselves that gives them permission to use. We're going to identify that unhelpful thought and help them reframe, identify a more helpful, balanced thought. We're really thinking again about social skills training. For adults, because they are the architects of the intervention, we are thinking about behavioral reinforcement. We're not really looking to punish adults, but we're really looking to help them find incentives for why they want to decrease their use, right? I always talk to my parents and I say, what's your prize? And how do we help you keep your eye on the prize? We're also going to be thinking about motivational interviewing techniques, again, those social ecological changes. We might be thinking about working alongside appropriate medical detox facilities. And again, just like with adolescents, we're planning and predicting for relapse. One of the things that is different for an adult and an adolescent in MST is we often do not support an adolescent attending AA. And that really comes back to brain development, for one thing. The other thing is that the time that they would spend in AA, we really want to get them into a pro-social activity. But with an adult, often they experience AA as being really helpful, and that might be a part of the intervention plan that we would then have an adult develop. And so, as you can see, MST really is a treatment that can address the behavioral kind of dysfunctions or disruptions of an adolescent, of an adult, of the entire family. And we lead to better outcomes for the entire family. We have a 22 plus year follow-up, and we've actually been able to see that MST has not only impacted the adolescent that we worked with, but we've been able to impact the sibling to reduce their arrest rates, to reduce their felony arrest rates, and also we've seen fewer caregiver felonies. And this data really showed us that we've been able to save up to $8,000 savings per family members. But what really sticks with me when I'm thinking about MST is what the families and young people tell us about their experience. And so we had the privilege about 2 years ago to hear from a mom named Sheila and her daughter about her daughter Faith and her experience of MST. And we're just going to share with you a small clip of what Sheila told us about her experience of the program.
On the left is a picture when we first started the MST. So in June, her GPA was 1.1. She wasn't attending school. She had negative peers. And now, April of this year, Faith has a GPA of 3.4, a 98% attendance rate. She follows all the rules. She's making positive life choices and changes. This child will now tell any negative peers, no, I'm not going in that car. I'm not going to the mall. I don't have any money. You shouldn't go to the mall either. She's leading, you know, her positive life choices. She doesn't want to go back through the Gilliam. She doesn't want to go back through having all these team members or any of the other things that happen. However, she will always come back to MST and Julie and say that was the best thing that happened to us. And that's the truth.
So I'm not going to lie, when I hear folks like Sheila talk about her daughter Faith and their experience of MST, when I hear other families talk about their program, I really do swell up with such great pride. I'm proud of those caregivers for the efforts that they have to take to really help their young person. I'm proud of the young people. I love hearing that Faith was able to say no to her peers. What a great example of that social skills training. And I'm really, really proud of the therapists who are out there in the field every day, really working hard to change the lives of kids and families. And so essentially, MST is an intervention that can address the disruptive behaviors in the young person, in the caregiver, and we can really impact that by addressing those ecological drivers or those risk factors that I spoke about earlier. But it's not just important to think about how we're doing it one family at a time. Also, MST is working to do large systems change. And so in 2003, in New Mexico, they looked at their Children, Youth, and Families Department, and they decided that they needed to shift their finances away from residential and incarceration and really look for programs that were going to keep young people at home and produce more sustainable outcomes. This led to the statewide implementation of MST. And from the New Mexico data report, we have demonstrated that we've saved $134 million when you compare MST to those relative other treatment programs. We've been able to see an 87% with no new arrest, and that's measured at the time of discharge. We've been able to see 75% of young people passing most classes and 84% of no new discipline problems in school. So I'm always going to link it back to what are we trying to accomplish with this act? And what we're trying to accomplish is really to address those needs of young people and families safely at home. And I think this demonstrates that. Right now, we're also involved in an international large-scale program. And so a report in New South Wales saw that their child protective system was really ineffective. It was really failing children of families with complex needs. And that inspired Australia to invest in transforming their child protective system. And they're using MST. So now MST is only one of 2 models in the New South Wales that's really helping them do systemic reform. And over 900 families are being helped each year. And these families include families of Aboriginal children. So I'm really very proud of the work we do. And I thank you so much. All right, I'll pass it to Josh then.
Thank you. So tying it kind of all together, chatting about MST, Child Welfare System, and the Family First Act. So the Family First Act's goals are to keep families together, support cost-effective, research-supported services for families, and MST is directly aligned with these goals. We're providing an individual treatment program for every family, and our outcomes keep families together and yield reductions in crime, substance abuse, and behavioral health claims to payers like Medicaid. And so the vast majority of youth that we treat are in school or working. And, we've talked a lot about MST's body of evidence, and that's led to a number of endorsements, including nods towards the effectiveness of MST from the CEBC, the UN, blueprints, and of course the Title 40 Clearinghouse. So, tying it back to the cost effectiveness goal of the Family First Act, MST isn't just providing quality clinical outcomes. We've also demonstrated over decades that we've been able to save taxpayer dollars by reductions in crime, placement, foster care, and again, behavioral health claims to payers. So a study published in the Journal of Family Psychology indicated that MST can yield an ROI of up to $23 for every dollar spent on the program. And that was kind of underscored by some recent cost savings reports produced by independent entities in New York and New Mexico and Pennsylvania. So in New Mexico, MST saved the state $134 million over a couple years, as well as $50 million for the state of Pennsylvania. So at the system level, states are evaluating options for program investment and timing. And states are essentially submitting a plan to HHS outlining which services will be provided, an implementation plan for those services, including a process to monitor fidelity, how the services being provided are expected to improve particular outcomes, how the state will monitor and oversee children receiving those services, how the state will assess eligibility, how the state's supporting or enhancing the workforce to support these services, and also what training and support will be provided for caseworkers. So programs are implemented statewide or will be implemented statewide and evaluated by the percentage of child candidates for foster care that are successfully kept at home, and also cost. And so, you know, in terms of how folks watching this webinar can participate, the first step would be to contact a member of our business development team to work with you on planning and implementation of an MST program. And so MST has a robust program development function, and we'll help create an enabling environment that'll foster long-term success of your MST program. So essentially, we'll have someone specifically assigned to work with you to navigate the complexities of starting an MST program. And you know, with that, I'll kind of conclude by saying we really appreciate the opportunity to chat with you guys. This is obviously a very important topic that we are very passionate about. So I'll open it up to any Q&A.
Any questions from the group? I'm not seeing any new questions popping up in the chat either. I think you did such a thorough job. People have their questions answered, but before we conclude, are there any other questions? Are you sure you don't have anything, you know, in the back of your mind that you're going to be sad if you didn't ask?
Well, our contact info is on the slide, and we'd welcome any questions offline as well.
Okay.
Absolutely.
Well, thank you so much, Josh and Lori, for both of you, for your time and for your thorough overview. It was very helpful to give us the deeper understanding of MST and all of the valuable outcomes that it can produce, and also how it fits so well with the Family First Act too, and outlining, you know, the understanding of that as well. So thank you so much. So
great. Thanks a lot.
Thank you for having us.
Thank you.
We'll send you some of those follow-up materials.
Perfect. And then I'll send out the link to the recording and all of those follow-up materials to everyone on the webinar, and also to our broader network too. So for those of you that are on the webinar, know that that'll be coming your way soon as well. So thanks everyone. Have a great rest of your afternoon. We really appreciate everybody's time.
Thank you.
Take care.
Thanks. Bye-bye.
Thank you.